neurosurgeon, you're going to hear from me, you're going to hear from an orthopedic surgeon, you're going to hear from a rheumatologist. Osteoporosis involves what we do on a daily basis. Neurosurgeons and orthopedists obviously deal with some of the sequelae of that disease, and we're sure that not enough is being done because we're just seeing too much of it. We're seeing too many fragility fractures in the emergency rooms. We're seeing too many people with fractures that didn't need to happen and subsequently result in huge problems, huge medical problems that you wouldn't anticipate happening to that person at their age. So we're going to start tonight with Sonia Manocha. She's a rheumatologist at AHN, Allegheny Health Network.
As Dr. Burgess said, I am a rheumatologist and I work out of Wexford mainly for Allegheny Health Network. So what is osteoporosis? Osteoporosis is a disease of the bone, of the skeletal bone, and if you look on the left, you'll see that that's a picture of normal bone, and if you look on the right, you'll see a bone that is osteoporotic. So bone that is full of pores and looks like Swiss cheese. The interesting part, if you look at the slide on the left, it's actually a 75-year-old woman. And if you look at the slide on the right, it's a 47-year-old woman that was menopausal early. So you can see that this is not just a disease of age per se, it can happen early as well for other factors. So as I said before, this is a systemic skeletal disease. It involves all of the bones. It's a disease of low bone mass. And this is deterioration of the bone tissue and the architecture of the bone that can lead to an increased risk in the fragility of the bone. And what happens when you deteriorate the bone strength or the bone mass like that, you lead to an increased risk of fracture. So I have several different definitions that I'll bring up a few times during this talk. One of them is the National Institute of Health consensus statement on what osteoporosis is. And for them, like I said before, it is a skeletal disorder characterized by compromised bone strength that leads to an increased risk of fracture. Now, when we talk about bone strength, that's actually two things. And if you watched the talk yesterday, which I also found on there, they went over this in detail and they did a great job at it. Bone strength is something that we have two components of. There's bone density, which is something that we measure with the bone density scanner, the DEXA, and then there's bone quality. Now, as I said here, bone density is measurable with the DEXA. Bone quality is something that's not quite as well defined. It's not measurable. It's something that talks about really the architecture, the turnover of bone, the accumulation of damage, different mineralization, and so forth in the bone itself. So if you look at the top and the bottom, you'll see the differences. Again, the top is normal bone and the bottom is osteoporotic bone. These are actually two slides of the same bone density bone. However, the architecture at the bottom picture, you can see the architecture is different. They don't have as many of these horizontal projections in there. So this bone has less quality and it has a higher risk of fracture. Now, how do you get osteoporosis? Either you start off with too little bone to begin with, and what we call that is low peak bone mass, or you can have too much bone loss. So it's a balance that you need to keep. You can also have a combination of both. So peak bone mass is the maximum bone mass that you have achieved during a lifetime. It's reached whenever the growth in the size of the bones and the accumulation of the bone mineralization has stabilized. And that occurs differently in men and women, and it occurs differently in different sites of the skeleton. So in here you can see the differences in peak bone mass in men and women. In general, women reach their peak bone mass in their mid-20s. From then on, they start to decline. And when you get to around a perimenopausal state, that decline happens more rapidly. Causes of osteoporosis. This slide is very minimal. This is only a few of the causes of osteoporosis. Of course, primary osteoporosis is due to aging. However, you can have secondary osteoporosis, and this would be due to a myriad of things. So as you can see up here, any kind of endocrinologic disorder, having too much calcium, having too little hormones, having too much parathyroid hormone, all of these things will influence your bone structure and your bone quality. Different drugs, so if you've ever been on prednisone or any steroids for any length of time, that decreases bone density as well. Any excess of thyroid hormones, anti-seizure medications, the list goes on. In addition, any malignancy can increase your risk of fracture. Rheumatoid arthritis and Crohn's disease, things that I deal with on a daily basis. Not only is it the medications that we give these patients that decreases their bone density, but it's also the actual illness itself. Also immobilization. So why are we talking about osteoporosis? Why is this such a big deal and something that we had on WQED and something that we're talking about today? It's very common, it's serious, it's a high cost to society, and there's a lot of morbidity and mortality associated with it. In addition to that, most importantly, if you ask me, it's preventable and treatable. So going into those, when we talk about the commonality of it, 54 million Americans have low bone density or osteoporosis. 1 in 2 women and up to 1 in 4 men that are over the age of 50 will have at least one bone break due to osteoporosis. And if you look at the bottom, the risk of hip fracture in a woman is actually equal to her risk of breast, uterine, and ovarian cancer combined. So this graph and the next graph are just kind of to go over this again, how common it is. And if you look here, you can see osteoporosis in the white for bone. And then you have high cholesterol, high blood pressure, and diabetes. These are all very, very common disorders in the United States. Not that one is more important than the other, however, this just says how common they are. And if you look all the way on the left in the red, you have osteoporotic fractures. If you calculate all the hip fractures, forearm fractures, and other sites, and vertebral fractures all together, frequency is higher than that of heart attack, stroke, and breast cancer combined. And this is back in the 1990s. Nowadays, this number is even higher. So osteoporosis is serious. As we've mentioned already several times, it increases your risk for a fracture. The common sites for a fracture are the hip, the wrist, and the spine, and I'm sure they will go into those in detail. Fragility fractures are fractures that occur with simple activities, a fall from standing height, less than that, activities that you generally would not fracture a bone. The problem is that when you do have a fracture, there's a lot of pain associated with it sometimes. However, if you have a vertebral fracture, sometimes you don't have pain. You can have loss of height, which that happens to me, that's a big problem. Kyphosis, that hunched over posture that you see over there, that can occur with several fractures. You lose mobility when these things happen. You have loss of independence, and furthermore, you have a risk for another fracture. So the preventable and treatable parts. We've had a lot of changes over time. In the 1980s, DEXA scans came about. However, we didn't have any reimbursement for DEXAs until the 1990s. We had our first medication to treat osteoporosis, the bisphosphonates, in 1995. And in 2008, we have a calculation called the FRAX score, which I'll go into in detail in a minute. So risk factors for osteoporosis. Heredity, your race, your gender, these are all very important. Osteoporosis is actually more common in Asians and Caucasians. Gender, it's more common in women. There's a lot of hormonal factors that go into this. Medications that we discussed, rheumatologic conditions, other medical conditions, and lifestyle factors. So the important part here is that there are some factors that we can change. Lifestyle factors like calcium, vitamin D, physical therapy, exercise, smoking, and alcohol, these are all factors that can be adjusted to minimize your risks of low bone mass. And just as I said, there are certain factors that we can adjust. If you smoke, it would be good to stop. Smoking actually increases your risk of low bone mass. And alcohol, too much alcohol, will increase your risk. We have screening tests such as the DEXA or the bone density scan that can help diagnose osteoporosis, and also we have treatments with medications. So diagnosing osteoporosis, any fragility fracture, regardless of your DEXA, is a diagnosis of osteoporosis. In addition to that, a bone density scan can also help with defining osteoporosis. So this is kind of a rough schematic of a bone density scan. Radiation is actually quite low with this. So guidelines for the DEXA screening from the National Osteoporosis Foundation are all women greater than or equal to 65 and all men greater than or equal to 70. In addition to that, any younger postmenopausal women or women in their perimenopausal transition and men 50 to 69 if they have any of the clinical risk factors. Also, any adult that fractures after the age of 50. So these are all clinical indications to get a DEXA, as well as any adult with a condition such as rheumatoid arthritis, taking a medication such as a glucocorticoid or prednisone at a daily dose of greater than or equal to 5 milligrams for at least 3 months. So why do we do DEXAs? They're good for diagnosis, as we mentioned. We have the T-score classification to help with diagnosis, and they can help diagnose osteoporosis before you have a fracture. Prognosis and fracture risk assessment. So the bone mineral density actually correlates with your risk for a fracture. And it explains 60 to 80% of bone strength in cadaveric studies. Monitoring as well. So when we talk about postmenopausal osteoporosis, and this T-score is only useful for postmenopausal osteoporosis, a level of osteoporosis would be anything that is a T-score that is equal to or less than negative 2.5. Osteopenia or low bone mass would be anything between negative 1 and negative 2.5. So again, these are all the guidelines. When do you treat? So first off, treatment goals for osteoporosis. They're twofold. One is to decrease fracture risk, so to prevent a fracture, and also to stabilize and increase your bone mass, to maintain bone quality, and to decrease your risk of falls. And the other treatment goal is to manage any existing fractures that are present. So most women with hip fractures don't have osteoporotic T-scores, which can be a problem. So in here you can see that 54% of these women, there's 243 there if anybody can't read, it's a little bit small. So 54% of them have a T-score greater than negative 2.5, however 46% of them do not. So then we get the challenge of how do we identify those with a high risk of fracture that could benefit from treatment. And that's where the FRAX tool comes in. So this is a risk assessment that gives you a 10-year risk of any hip fracture or all osteoporotic fractures. It's based on several different risk factors as well as femoral neck bone mineral density from the DEXA. And it was based on a worldwide cohort involving several individuals over several years. So this is the FRAX calculator. If you go online, anybody can access this. You plug in basically where you're from, if you're Caucasian, if you're from Europe or from Canada, any of those categories, and then you calculate out based on your age, your sex, your weight, your height, whether you've had a previous fracture, whether your parents have had a previous fracture, if you smoke, all of those characteristics go in here. And those are the characteristics that they found added up to an increased risk of fracture. And based on that, if you have, at the bottom you can see in the red, if your major osteoporotic risk is greater than 20%, or if your hip fracture risk is greater than 3%, that's actually an indication for treatment. So again, when you treat, these are the National Osteoporotic Foundation treatment guidelines. If you have a fragility fracture of the hip or the spine, a T-score on your DEXA of less than or equal to -2.5, and if you're osteopenic, in addition to a FRAX calculation with a hip fracture probability of greater than 3%, or all osteoporotic fracture greater than or equal to 20%. So non-pharmacologic treatment recommendations are supplementations or vitamins. Those include calcium and also vitamin D. Generally with the calcium, if you can increase your dietary intake, that's great, but for the majority of people, that's not always a feasible method. So the recommendation is about 1,200 milligrams of calcium a day, and for vitamin D, anywhere between 800 and 1,000 units a day. But in addition to that, we can always check a vitamin D level. If you're deficient, certainly you need a higher dose. And Pittsburgh doesn't always get the greatest amount of sun. In addition to supplements, weight-bearing exercises and muscle strengthening exercises are very important. Smoking and alcohol cessation, as well as fall prevention. So again, little plug for calcium. And this goes over the guidelines again, and vitamin D. So advancements in osteoporosis medications. We've had several different changes along the way with diagnosing, and we've had different changes with treatments. I'm not going to go into all the details on different medications. I'm just going to point a few of them out. Once we get to 1995, we have alendronate, which is a bisphosphonate. Bisphosphonates are medications that can be taken either orally or intravenously. If you look down, ibandronate as well as zoledronic acid are our 2 IV medications. These are medications that help to prevent bone resorption. They do not build up bone. Now, when you look in 2002, we have teriparatide, which is otherwise known as Forteo. This is a medication, the first medication and only one that we have at this point, that actually builds up bone. It's a medication that you inject, it's subcutaneous, you inject it once a day. You can use it up to 18 months, and it really does help to build up bone mineral density. Denosumab is the one that came out in 2010. It's actually the first monoclonal antibody that we have. And that is again a subcutaneous or intramuscular preparation. And it can be given once every 6 months. So in summary, osteoporosis is a condition of low bone density and decreased bone strength that increases your risk for a fracture. Bone fracture may lead to pain, loss of function, and loss of independence. Importantly, we have screening methods to determine those at a high risk for fractures, and modifying lifestyle can actually help to keep your bones strong and prevent a fracture. Guidelines, of course, are to suggest a DEXA for all women greater than or equal to 65 and men greater than or equal to 70, along with the other recommendations mentioned if you have risk factors. The goal, of course, is to minimize any fracture risk and to manage existing fractures. And the FRAX score may determine those that are in an osteopenic range that have a high risk of fragility fractures. So I don't know. Thank you very much.
Our next speaker is Dan Altman. He's an orthopedic surgeon at AHN.
What I was going to do is I want to talk about orthopedic manifestations of osteoporosis. Better, right? Okay. Orthopedic manifestations of osteoporosis. First, I'll introduce you a little bit about my background. I am one of the orthopedic surgeons at Allegheny and one of the directors of orthopedic trauma there. In that role, I do not do a lot of general orthopedics. I did 2 fellowship years, one in spinal surgery and one in orthopedic traumatology, which is taking care of the severely injured patient, the ones that are coming off the helicopter. So we do see a lot of osteoporosis, and it's even compounded when you have trauma on top of that. So Allegheny County, we always say, is the second or third oldest county in the country. So we see a lot of osteoporotic fractures. On top of that, with with trauma. So it's a huge topic, and how many saw this? This was just last week in New York Times. So yesterday night there was the article, there was the WQED series. Last week this was headlines from New York Times about osteoporosis drugs and just the awareness of osteoporosis. So it is a big factor, and it's affecting more than just Allegheny County or older populations. It's prevalent throughout the world. We're just going to talk about it briefly, and there'll be some overlap, which is always good for me because I have to hear things like 10 times before I understand. But the definition of prevalence, we're going to talk about risk factors, and then we'll talk about some orthopedic consequences of osteoporosis. So we talked about that. I think it's just a disorder where the bones become porous, brittle, and subject to fracture. So you're going to keep hearing this word fracture, break, and it's amazing how many times the fracture is just a complete break of the bone. So there was a few questions earlier on this. So actually bone is a living organism, and so it's just not this static structure that we have. It's living and it's constantly turning over. So the highest peak mass is in your 20s, especially for females. And then as we get older, there's this constant struggle between building new bone with a certain type of cells, osteoblasts, versus the breakdown. And that's where understanding that and understanding how dynamic bone can be and how there's other factors on bone. And there's the factors of how drugs affect. And if we look at it as an organ, then it sort of makes sense a little bit. And osteoporosis is when you have too much breakdown, not keeping up with building the bone. So we talked about this. I think the key factors are 1 out of every 2 women over the age of 50. So these are the women that made it to over the age of 50, though, will sustain an osteoporotic fracture. And we talked again about osteoporosis risk is higher than the risk of breast cancer, heart attack, and stroke. So it is a big national healthcare crisis, and there is this increased emphasis. So let's review again fragility fractures. So you can fracture or break your bone at any point in life. It's when your bone breaks for unknown cause, and I'm sure we've heard of that before, someone saying, listen, I don't even think I fell. I feel my hip broke before I even fell. So it's a fall from standing height or less, or can occur in the absence of any trauma at all. These are fragility fractures. The most common site is the spine. Dr. Burgess is going to talk about that. The hip is the second most. Then there's the wrist and the shoulder. Now, how many people here do have osteoporosis? Raise their hands. So that's about half, at least half the audience. How many people here know someone that had a hip fracture? And so now we're close to 100%. Another question. How many people here had a hip fracture? So that's pretty good. There's only a few, but 100% new people with a hip fracture. So we're gonna talk a little bit more about these. I just wanted to mention the vertebral compression fractures. They're your #1 fracture. There's 700,000 of those a year. But Dr. Burgess is going to really give us a detailed lecture on that. Again, why is this important? Well, one, we've all known someone that's had a hip fracture. It causes 2 million broken bones a year, and the cost is $22 billion. So the U.S. government is involved with this too, and so should every physician or healthcare provider. It's up to us. If I take care of someone with a spine fracture or a hip fracture, and I don't address their osteoporosis as well, I feel I'm negligent. So when we're taking care of these patients, we also have to address their osteoporosis. Specifically, if we talk about hip fractures, there's more than 250,000 per year. 70% of these occur in females. 50% of the patients that sustain a hip fracture will lose their ability to walk without assistance. So half the people with a hip fracture will then go to a cane, walker, or even wheelchair. 25% will require some ancillary care afterwards, either a skilled nursing facility or inpatient rehabilitation. Actually, I wanted to define the hip fracture because we hear all this terminology and stuff. So the hip fracture is really where the femur attaches to the pelvis, and that's the hip socket, that's the acetabulum. Most of the breaks occur either in the femoral neck, and it's on your left, where the ball attaches to the long bone, and that's a femoral neck fracture. And so your fractures can occur either there or lower down. You also hear, in some cases, a minor pelvic fracture. So you can have an osteoporotic fracture of your pelvis bone, which doesn't need operative care. Almost every single hip fracture requires operative care. And then there's these atypical femur fractures. And the atypical femur fractures are what's been the buzz lately in the past couple of years. And these are fractures that occur after someone has been on treatment for osteoporosis. So this is a big point I want to make is there's these osteoporotic medications, and thank you, sir. 1 in 50,000 who's been on the bisphosphonates are predisposed to this. So this fracture here is different than up here. It's a more difficult fracture to treat, and for this reason alone, there's been a lot of patients afraid to be treated for osteoporosis. However, I will caution you that the risks are phenomenally higher for the patients that are not treated. So, although that's a very reasonable question, the side effects are either another type of fracture or this osteonecrosis of your jaw. The vast majority of people still should be treated. The only caveat that we've learned in the past several years is that if you have been on one of these medications called a bisphosphonate for more than 5 years' time, and it's possible, you should take a drug holiday. And a drug holiday can be defined as 1 to 2 years' time off the drug. The reason for a drug holiday is once that drug is in you, it lasts for years. So you're building up this level of the bisphosphonates, and they can last in the bone for many years. So what about the treatment of your more typical hip fractures then? This is the vast majority of out of all 100 fractures, 99 hip fractures will be from osteoporosis. Way less than 1% will be from people on the medication. So this is where we have all the different treatments, and that's where, why do some people get screws, some people get rods, some people get a hip replacement? So if we go through, the first goal is, if we can, we try to save your own bone. So if it's a type of fracture that is amenable to screw fixation, we can put these screws into a minimally invasive approach. You can be up walking the next day. These are usually what we call non-displaced fractures without the whole head coming off. Again, when we first started this lecture, we talked about bone being a living organism. So if this ball comes totally off the femoral head, it loses its blood supply and it can die even when you put the screws in. If it's a younger, and we define younger as physiologic age. So if they're an active person, they come in, they're 80 years old, they came off the tennis court, we're going to try every way we can to save their own bone. Now, if they're physiologically much older, then we'll give them a one-time surgery, which would be a hip replacement. So people say, well, should we just get the hip replacement anyway? Anyone that's ever had a hip replacement knows it's a lot of rehab afterwards, and it's never as good as having your own hip. The exception here is if you have, and we see these people all the time, if you have someone coming in that's already had pre-existing arthritis in their hip, and they say, my hip's been killing me, and then it broke, then that's a time where we probably go forth with the hip replacement. So treatment options really vary. It depends on type of fracture, it depends on the lifestyle and the physiologic age of the patient, and it depends on their medical conditions, any pre-existing arthritis in the hip. And again, the best time to initiate workup or treatment is after the fracture. So there's literature out there that, and you guys seem to be the more active people. You're here wanting to learn about osteoporosis and everything, but there's literature out there about 20% of the people actually go forth with treatment for osteoporosis that know they have it. And the best chance you have to try to influence someone is right after their fracture. So what they'll say is they'll listen to their orthopedic surgeon, especially after a fracture, but their primary care doctor might have been telling them for 5 years. Similar to my mom. Hey, you should be on a medication for osteoporosis. And if they don't realize what's happening to them, then it doesn't phase until they've had that fracture. So it's also been defined as a silent killer. And why is that? Well, one, hip fractures, 2 to 3% will die during their hospital stay. Another 20% will die during the first year. Now again, this is looking at all comers. So it's not as devastating as it looks like. There's so much variation in the people that have hip fractures. So if there's a percentage of people that are already weak and feeble to begin with, they may be at the nursing home, fell out of bed, have difficulty standing, there are going to be those 2 to 3% that are at higher risk for dying during their hospital stay, and then this 20% die within a year. And it may not be per se the fracture, it may be this was a marker that this person was going downhill, or it may be the fracture in their treatment, them having to leave their home, them having to be less weight bearing, higher risk for blood clots once they get a hip fracture. So these are some pretty impressive numbers, and that's why it's sometimes referred to as the silent killer. A prior history of an osteoporotic fracture is the strongest predictor of a future fracture. So if you've had one of these fragility fractures, it's essential that you do everything to change your lifestyle and get treated, because that's your biggest risk of having another fracture. Again, fractures lead to more fractures. What are the other osteoporotic fractures? And they're the wrist, or we also call it the distal radius, the shoulder, and sometimes the ankle. Patients with fragility fractures have 2 to 4 times greater risk of another fracture than all comers. And then there's some other interesting facts down here. If you've sustained one vertebral body fracture, you have a 50% greater chance of sustaining a second fracture within the next 3 years. But you also have a 6-time risk of sustaining a hip fracture. So if you've had a vertebral body fracture, Dr. Burgess is going to talk to us about those, and you think, okay, I'm feeling better now, I wore a brace or I got treated, you better be careful because you have a 6-time chance of getting a hip fracture. Our academy, the American Academy of Orthopedic Surgeons, is very proactive, and this has been in the past decade that there's been this big push for osteoporosis, educating the patients and educating the surgeons and physicians as well. So it shouldn't mean hip fractures, disability, and loss of independence, and those are some of the things we face. We talked about the risk factors. I will tell you some of the interesting risk factors are the ethnicity. Now we've heard Caucasian and Asian women are at the highest risk. And the other thing that I just look at without looking at the data is the frailer patient that comes in fair skinned. So the highest risk is fair skinned females. Also, the other interesting things is it's your descent. If you're from Northern Europe, you're more fair skinned, and it has to do with your vitamin D and the genetics of metabolizing it. You're at a higher risk than someone from Sicily or Barcelona. The other thing that I've only seen one time in the past 15 years is an African American male with a hip fracture. It just doesn't, African American males don't get osteoporosis, and if they do, that's when we look for the secondary causes with our rheumatologists and our medical colleagues. So what are the factors that you can control? And I'll just come at this a little bit differently, but we've heard this, is the inactive lifestyle. And it's the people that spend time sitting that instead of being active. Who else sits? Well, sometimes it's the medical team's fault or the orthopedic surgeon's fault, or it's no one's fault. But if they're having a surgery where they have an abdominal surgery, where they had a foot fracture and they're less ambulatory and less weight bearing, they're at a risk to get another fracture. So it's just any reason why they're not walking or maintaining this active lifestyle. Again, alcohol consumption, it should be reasonable, less than 2 drinks per day. And smoking has a terrible, terrible impact on bone health. How many people here smoke? So really, I didn't see any hands, and that's a great thing. And again, there's a lot of different reasons for this, but when we see with bone metabolism, it is a terrible thing. And in fact, if I'm doing an elective spine surgery, or if I'm doing a redo fracture, I will put that patient off if they're still smoking. I need them to be at the best host they can be for surgery. So we feel that strongly now about smoking and the adverse effects on bone healing. We reviewed the DEXA scanning. Who should have a bone density test? And again, these are the risk factors are inactive lifestyle, smoking, excessive alcohol use, and then the low calcium and the vitamin D. And again, the vitamin D can become from where you are. There's a higher risk of fractures, hip fractures in northern United States than southern United States. So what do we mean by this active lifestyle? And it's really easy to say. And I get a lot of questions from patients, well, I like swimming, is that helpful for me? And yeah, that's helpful for aerobic exercises and for conditioning, but it's weight-bearing exercises. Again, if we go back, bones are healthy living organs, and they need weight-bearing to make them turn over this bone. So walking is better than biking, which is better than swimming. So although swimming is a great exercise, it does nothing for osteoporosis. Tobacco, I think I said enough on this, but how it works is kind of interesting too. We don't know all the factors, but there's been a lot of testing and a lot of literature on higher rate of non-healing bones, non-healing osteoporotic fractures with tobacco. And in fact, when we report stuff in the literature now, we report smoking history versus non-smoking history with every single fracture. Smoking decreases the ability to absorb the calcium, and it also decreases this bone density. Alcohol use, regular alcohol, more than 2 drinks per day. And so what are some of the other factors? Well, if you're drinking, you're more likely to have poor nutrition. And so that we go back to this nutrition, this vitamin D and calcium intake. And then also, if you're drunk, you're a little bit higher risk of falling. Balanced diet really is important for the bone, and we talked about this. Sensible exposure to sunlight, so we don't need the dermatologist coming down on us, but 5 to 10 minutes, 3 to 5 times per week would be considered sensible sunlight exposure. And then so treatment, calcium, vitamin D supplementation under the direction of a healthcare provider. I would say at least once every couple months, and it's maybe once a year. We have a patient that thought they were, and we try to educate the patients because that's our best patient, the one that brings literature to us and the ones that we talk, but they have a hip fracture and they think they're going to just keep taking more and more and more calcium. And so if someone didn't get to them and say 1,200 milligrams a day, we've had people come in renal failure, we've had people come in with sky-high calcium, and that's because they're maybe taking 10 calcium pills a day. So it's, I usually think about 1,200 calcium, 800 vitamin D, and it varies a little bit depending on your overall levels. I encourage these prevention strategies, fall prevention, and these again, these are things that are kind of common sense, but we should discuss this with our patients, especially the elderly patients that are leaving the hospital that may be a little bit more frail. And so sometimes I would like them just to use a cane or walker for added stability. The worst thing, and unfortunately this happens too, the worst thing is someone that has a hip fracture, they're not stable, but their hip bone is healed and they're still not stable. Well, they're real anxious to get off the cane or walker, and they come in and they broke the other hip. So safety is paramount. And normal things like keeping the floors free of clutter, using railings, and ensure lighting. And these are all important things. So let's just summarize all the things we talked about. One, and you can't go back to this enough, and I don't even have a great balanced diet, but it is really important. The weight-bearing exercises, we talked about bone being a living organism and it needs constant turnover. Smoking cessation, smoking is terrible for bone healing. The people that are at risk would be men over 50 and postmenopausal women. And then this calcium, there's good literature now, the calcium and vitamin D supplementation, as well as some of these medications, can reduce the fractures by about 50%. So we saw that huge numbers in the beginning, $22 billion. So if you're even knocking off 10% of that, that's a lot of savings to society too. There is some additional information. Our academy is very active in this. American Academy of Orthopedic Surgeons, they have a great website on us. And then we, National Osteoporotic Foundation. So let's root for the Pens tomorrow. Thanks.
My talk is going to be strictly about spine. I'm not going to talk that much about treatment. You've heard that. But it's so incredibly important to have a spine that works when you're 80 years old. Talk to anybody that's bedbound or bound to a wheelchair or in a walker, and that would be their highest wish, is to not have to be in that situation. Think about what we actually have in our back is that multifaceted 33 pieces of bone that not only contains our spinal cord and spinal nerves that allow us to move, but also maintain us in a very strange upright position throughout our life. We can run, we can walk, we can do acrobatics because it's there, and we have this fine motor control over it. Think of how strong those elements must be to take those kind of stresses and strains over the course of a lifetime. That happens because the bone's maintained by the body's physiology. We talked about removal and renewal of bone. That's controlled by specific cell populations. The osteoclasts are the ones that dig through and take away the bone that it senses has been there too long. The osteoblasts follow those along and lay down new bone, and that's a constant cycle that's happening again and again in all of our bones, in every bone in our body, in every bone in everybody's body here. The onset of osteoporosis in a normal population usually begins around the time of menopause in women. That's its first time when you begin to see real clinical effects of osteoporosis. There are two types of osteoporosis. One is the estrogen-associated osteoporosis. There's the other that's age-associated. Those are two very different things. When you're 75, it doesn't matter if you're a man or a woman, the same processes are going to be going on in the bone, in your spine, hips, everywhere. And that's not amenable to, say, hormonal therapy, whereas estrogen therapy is, or rather, estrogen-associated osteoporosis in a younger woman is amenable to treatment. And men too. The estrogen doesn't slow down just osteoporosis in women. Men also need estrogen in their bloodstream to maintain normal bone growth throughout their middle years. Okay, we talked about DEXA scans. I figured if I was the last one to talk, the least I could do is tell you what DEXA stands for. It's dual energy X-ray absorptiometry. And the explanation, it's worth knowing. Sonia told you, it's a very low exposure to radiation, but it's two radiations that happen simultaneously. And they subtract out the soft tissue densities that way, and then they can calculate the density of what's left of the bone. And we talked about the standard deviations below which average bone is healthy and above which it's not. So the number of men 50 years of age or over with osteoporosis, fever in the neck or the lumbar spine, 4%, very small number. Percent of women 50 years of age or over with osteoporosis, of those two places, 16%. In the United States, approximately 35% of women 35 or 65 or older have osteoporosis. There are gender and race differences. You've heard about the gender race differences. That's more genetic than race, but the resistance of the black races to osteoporosis is perhaps gives us all hope that there may be a way to benefit our own susceptibility. Caucasian women have higher fracture rates than black women. Black women, however, have poorer outcomes when they do have osteoporotic fracture, and that's probably multifactorial. Okay. In case you don't have a mental picture of what osteoporosis looks like, here it is. Healthy bone versus osteoporotic bone. Now, if you can imagine in the healthy bone, this interstices built by these bone fibrils through the marrow of the cavity, the medullary bone, as opposed to the cortical bone. You can imagine the osteoclast and the osteoclast. Speaking to the mic. I'm sorry. You can imagine the osteoclasts and osteoblasts crawling along those fibrils, laying down bone and picking up the old bone. But you can also imagine if those aren't there, that process can't happen. So that the loss of that medullary bone or that network of bony fibrils adds to the problem of osteoporosis, is that it mechanically prevents the bone from reprocessing. Okay, an osteoporotic fracture. It will present, in most cases, sudden back pain. We're going to see some pictures of a vertebral compression fracture, but that can be painful. Perhaps it's not going to be painful. Think about what's happening. Through that vertebral body is a portion of the vertebral canal where the spinal cord passes through. You can imagine what would happen if the spinal cord is injured. in the instance when that's happening, you paraplegic, quadriplegic. But almost always that does not happen. The bone simply pancakes down, it flattens down, and the spinal canal is still papered. It is, however, whether it's painful or not, a marker of bone fragility. This is, as you heard mentioned before, fragility fracture. Once this happens once, your chance of it happening again increases geometrically. I'll show you why that. First I'm going to describe here the ideal spine. The ideal spine isn't a broomstick, it's not straight up and down. What it is a finely curving instrument that allows for the stresses and strains that the normal spine has to is exposed to. Only in one plane, but it only has to be in one plane. So you have the thoracic kyphosis, which is that curve right there. Then you have the lumbar lordosis. Those are two terms that describe the slight curve that way and the slight curve that way. And those play a major role in how the spine fractures and what happens as a result of those fractures. Look at this here. We have two, we have normal in the middle, kyphosis on one side, lordosis on the other side. The darker line is the kyphosis. The darker line is the normal spine. This one out here is the kyphosis. It's the exaggerated curve up this way. Here we have the lumbar lordosis, exaggerated curve that way. So if you can imagine a kyphosis is your back sort of back like this, I'm exaggerating that. And the lumbar lordosis happens because you're compensating for the kyphosis. If you're over like this, you're going to want to see what's in front of you. The tendency is to look to the horizon. So the only way to do that is to rotate your hips like this. Bend your knees. And that causes a hyperlordosis here, the kyphosis in the thoracic spine due to the fracture. And that's the way you have to walk. That's the way you have to live. Here is a typical kyphotic spine. Exaggerated kyphosis here. You can see for this person to look forward, he's going to have to throw his neck back and his hips forward. And this is the result. This is the end result. This is a very common sight in the elderly untreated osteoporosis. The spinous processes are here. And why can we see those? Well, normally you don't see that in the spine. Normally you see on either side a muscle bundle that hides that. But you don't see it on there, and the reason why is because these extensor muscles on either side have atrophied. And why have they atrophied? They've atrophied because they can't extend the spine anymore. You're just cut over like this, and no matter how much you want to extend your spine, the term is ankylosed. It's basically become stiff. It can't go up like that. If it can't go up like that, the muscles can't make it go up like that. So this is the very beginning of how this happens. And the process I'm going to describe is how the angle of the bodies, vertebral bodies, vary over time with the fractures, and how that results in the kyphosis. So this is a sudden fracture, an axial compression down. Say you fell to your knees or fell on your rear, and that compression was straight up and down. It's called an axial compression fracture. And the only thing that happens here is that they sort of fragment. that matrix inside the bone, which is not, which, as I mentioned before, is sort of, it has lost its integrity in terms of holding the vertebral body together under force, is a bit fragmented. You can hardly see it in this one. This is a brand new fracture. Things are going to happen here. Because the integrity of that is broken apart, you're going to start seeing the vertebral body assume a sort of wedge shape. This is going to be up, this is going to be down. Notice that's not the case with these other ones. These no longer are integrally associated with the rest of the bone, and these discs on either side of it are pushing up from here and down from here. So they're going to cause that body to go into a wedge shape if they can. And here's a finished product of that. It doesn't look very bad right there, but multiply that by 5 or 6 different vertebral bodies, and you're going to get a healthy kyphosis on that. I showed you an initial fracture that had not immediately compressed into a wedge. This is an immediate fracture that compresses into a wedge. That's very common too. So kyphosis is a postural change. It's an exaggerated thoracic curve. The weakened thoracic extensor muscles develop over time, not immediately, and that's important. They are due to anterior thoracic vertebral compression fractures, and the larger the curve, the more the extensor muscle involution. That simply means the more the thoracic vertebral bodies are compressed and wedged, the more of the extensor muscles, like we have here in this picture there, are involuted or atrophied. Okay. This is, but early in the course of developing a kyphosis, you can undergo treatment. This is usually physical therapy. They're treating early kyphosis with extensor muscle treatment. And these are a couple of those treatments here. I think this will play. It may be really loud or really soft, but I don't think I can change it myself.
Okay, so we're going to go through a few exercises. The goal is to strengthen these muscles here and in the front here without really throwing and trying to keep us, we're trying to get out of this posture here. So we're trying to bring this sort of more there instead of being very lordotic. And then we're trying to come up here, and then the head is trying to go from here basically to there. Alright, so there's a few exercises we want to add. So one of them is just some neck flexor exercises. So normally we do this exercise here where we sort of nod the head. And we work the deep neck flexors. Alright, like so. We're sort of sliding the top of the head that way. We hold it like this. To make it a bit harder, what we're going to do is bend up the knees and try and do the same thing as well. And that increases the demand because there's tension in the back through here. Some of the tissues here, we've got to fight against those to do that. Right, now if that was easy, then what you can do is try and lift the head slightly and maintain that position, but I think that's a little bit early for now. So we've got those. And then we have these ones here. So the problem is that we're pretty round and the head's down and we're trying to get the strength to sort of stay upright. So there's 2 exercises here. One is, if you want, you can help with your finger if the head is too weak. I'm pushing my chin backwards And I'm going to hold. Right, I'm not letting the chin come forward on it, so I'm just holding here. Alright? So if I only can move to here, push on the chin and help it go further. Or have a family member push on your chin and your forehead. So you hold it here, 10-second holds. So I want you to do that one. Then the other one is sort of, we're here. I want you to bring the back of your head towards your butt. So we're going to go all the way back. Hold. 10-second holds also. And then there was 2 others. Maybe just shoot over here a bit. See if we can see me. So one other one would be, it doesn't work so good with that chair. So we have a stool. And it's basically doing the neck flexor ones. Can you see me? So doing the neck flexor ones in the chair here. So we're going to slide the head up. Try and bring the abs. So instead of having the back super arched, bring the abs against so the back's as flat as the wall as you can get it. And then I'm trying to nod. So the back of the head is sliding up the wall. Alright, so we're doing that one. And then the other one is, so then the other one we're trying to do is we're trying to strengthen the muscles to pull us back like this. So you can get a sort of straight back chair. If you want to make it even harder, get your foam roller, and your back isn't going to move as much. Alright, so we want to move the head relative to the upper back, instead of sort of, now when we move the head, the back sort of goes with it. So I want to keep this forward, the head's going back. So either use a foam roller or just the back of a straight back chair. This is a rubber band. You'd have to tie this around a pole. So imagine there was a pole here. I couldn't do this with my hand, but there's a pole. I've got it flat here. It wants to pull my head into the bad position. But I pull back against it. And the objective is chest forward, head back. That's why we want the back of the chair. Like I'm fine, I can do it. But if I was super weak, probably I could use this. And the foam roller is blocking my upper back. Alright.
Can I buy a section that small? Mine is longer and I don't really want to cut it.
Oh yeah?
You get the idea. The point is extensor exercises is what you'll see when you're sent for physical therapy, which brings up, just to digress for a second, how patients with these compression fractures are treated. Fall from standing, FFS. We see that acronym on the charts from the emergency room all the time. In a trauma center, you're going to see a lot of this. These are patients that are very easy to take care of. They come to the hospital, they get their x-rays, they get a CT scan, maybe an MR scan. They'll be taken upstairs to the hospital bed. X-rays will be reviewed, a brace will be ordered, and they're home. A lot of times, the fact that this is truly a fragility fracture is not noticed, not noted down to be a problem within the patient's chart, not noted to be a diagnosis. I think orthopedics of all the disciplines have been very proactive in terms of making sure that the patients that they see with osteoporosis are evaluated and treated. I think neurosurgery and other people that deal with spine have historically not done that. That's one of the reasons I'm interested in this now is that too many people are making it through without physical therapy. Too many people are making it through without a diagnosis and a referral to a rheumatologist. That's and a referral to physical therapy. But speaking of braces, this is a typical brace you would put on somebody with a thoracic compression fracture. Now, whether these do any good or not is arguable. People say they feel good. It's sort of like a work belt. They feel safe in them. But whether this helps the healing or helps to diminish the amount of pain that the patient experiences is questionable. This is, what you're seeing right there is a sort of backpack brace which goes around the abdomen and over the shoulders. It sort of reminds the patient of what their posture, make sure that they think about standing up straight. These are certainly an improvement over the old plastic clamshell braces we used to use, which was 2 hard plastic shells put around people and held there with Velcro. And those never fit anyone very well and could cause skin problems and such. And just clearly we're now rethinking the use of these things. Okay. So I'm mentioning other kinds of kyphosis here, just to give you a broad appreciation of what we actually see. Now, kyphosis in osteoporosis occurs because the vertebral bodies themselves change their configuration. But that's not always the case. There are other reasons why kyphoses occur. This is one of the, I may have misspelled Sherman's. This is a adolescent kyphosis called Sherman's disease. It normally happens in adolescent males, occasionally females, and it can be disabling. This here, what you're looking at, is a disabling Sherman's, which is truly a kyphosis that would prevent him from doing most normal activities. Here's a Sherman's that's corrected. This is a medical condition that can be corrected with surgery. What you're seeing here is a before and after picture of a young man who has, I don't know how many screws in his spine, connected by 2 rods up and down the spine that's allowing him to stand straight. That may seem a little bit more surgery than anybody should have to go through, but this straightens up someone's spine and gives them a life again. This works in Sherman's. This would not work in osteoporosis. Scoliosis, another evidence of not necessarily a kyphosis, but a kyphoscoliosis, where the curve is very complex and the spine does not stand in this straight, the nice kyphotic and lordotic curves that you saw before, and it's distorted. And there is a neuromuscular reason why this is happening, that the muscles are not holding the spine in a normal configuration. But a surgeon can make this straight and a useful spine, with again a very, very extensive surgery. This is just a picture of the way the surgeons measure the various curves that do happen in patients with these various kyphoses, scolioses, and lordoses. Their goal is to return a patient's angles, thoracic and lumbar and lumbosacral, to a normal configuration. And that is an entire discipline. They do a marvelous job in giving people back a useful life with a very significant disability. The reason I mention this at all is that I'm sure that if this were possible in kyphosis, in compression fracture kyphosis, in osteoporotic kyphosis, we would do it. The problem is that all those screws you saw in all those young people were placed in very healthy bone. The bone, you can think of it as a screw, a wood screw in a piece of oak. You put the screw in, it will hold because of the nature of the material you're putting the screw in. In an osteoporotic spine, it's very different. It's the bone simply does not have the holding power to hold the screw. So if you're going to do a fusion and instrumentation of a spine in a patient with osteoporosis, you're going to have to do a very extensive surgery to try to put as many screws in as possible to get as much holding power as you can. And that can be a very, very extensive operation in a very old person. There is, however, a surgery that we do that has at least some claim to improve the outcome of patients with painful compression fractures. It's called kyphoplasty. Can I see the hands of anybody that's heard of that procedure, kyphoplasty? Okay. Kyphoplasty is a procedure by which the compression fractures are entered from the back of the spine with a needle into the middle of the compressed spine. The needle allows you to put a trocar in there and finally place a balloon into the vertebral body that's compressed. Inflate the balloon, opening up a cavity within the fractured vertebral body, one on each side, as you sort of see the picture here, and inject, take the balloon out and inject cement into the vertebral body. The cement does not heal into anything. The cement is there merely as a spacer and a means of stabilizing the compressed fracture. The only reason you would do one of these, in my opinion, is to ameliorate pain. The very name kyphoplasty sort of suggests that the kyphosis can be changed with this procedure, and I don't believe it is. It's never, this procedure's never changed that kyphosis into a normal spine angle that I've ever seen. But it does, it has a very good record of diminishing pain. I have a movie, but I think I can simply just walk you through it. Here's the needle that goes into that spine that's collapsed. The needle then allows the insertion of a balloon. The balloon appears black in this because there's iodine dye in it. That opens up a cavity within that vertebral body. You take the balloon out, you inject the cement into it, and what you see in the bottom two pictures there is the cement in that cavity made by the balloons. It's sort of like a brace, an internal brace. As I mentioned before, and I won't go into this here, the spinal fusion and instrumentation in the kyphosis and osteoporosis is done very, very rarely, and only in most, only in a situation where the pain could not be addressed in any other way. There are also compression fractures that turn into burst fractures, which cause compression of the spinal cord. And with an impending paraparesis, paraplegia, due to the osteoporotic fractures, that leaves the surgeon no choice but to go in and take the bone fragments off the spine and do the best instrumentation and fusion they can. So that's essentially the neurosurgeon's role in osteoporosis. We, as I was mentioning before, we owe our patients a little bit more in terms of getting involved in their osteoporosis, their care, and making sure that when they leave our offices, they end up in somebody else's office who's going to make sure that they're medically taken care of. This is a problem easily taken care of for all on the same team. So I'm going to leave it there.